Before I get started, I just want to thank Jolt and Melinda and the rest of the steering committee for the opportunity to be here. Thank all of you for coming. I know it's early. I know there's lots of other things you could be doing. And I also want to thank my colleague Colin Conway. A lot of the slides that I used here are based off of a slide deck that we developed together for this project. So, okay. So, are there any other people in here working on the Accountable Health Communities grant from CMS? Quick show of hands. One. Okay. Well, yeah, Colin, you don't count. Okay, great. So I will try to stick to this timeline. No promises, but I'll do a little bit of background about Oregon. Really quick, who's been to Oregon? Wow, okay, quite a few people. So if you're familiar, then you can, maybe there's something new in there. I'll talk about our recruitment and engagement strategy for the project. What I really want to focus on is how we've developed this project across more than just primary care. So this is not just a primary care initiative, this is happening all over the place. I'll talk about some successes and challenges that we've had and then leave plenty of time for questions at the end. So let's start with just a little bit of background about us and about our state. So Oregon, we are the Oregon Rural Practice-Based Research Network. We are a research department under the Department of Family Medicine at Oregon Health and Science University, located in Portland, but we like to think of ourselves as a statewide campus. We have rural outposts all over the state and people that work for OHSU working in all corners of Oregon. Our mission is pretty broad, so we are trying to improve health outcomes for all Oregonians. We do that in a lot of different ways. So we do research, we do a lot of work with community dialogue, coaching, and education. There's a lot going on, and we're a rapidly expanding team working with a lot of practices across the state. In 2018, we worked with over 300 clinics in Oregon, and that translated to about 1 in every 5 rural Oregonians receiving care from a practice that we worked with, which is pretty incredible. And we use what's called a regional facilitation model. So if you look at our map of our state here, the main hub of ORPRN is up in the top left. That's Portland, where most of the people are living. And then we have other facilitators located around the state. So I live in Southern Oregon, so that bottom little hub there, that's me. And I work with practices mostly in Southern Oregon, sometimes expanding out to other parts of the state as necessary. So I have been with ORPRN since 2015, and I've had the chance to work on quite a few different initiatives. Like I said, we are not sort of one lane. We have a lot of different things going on. So I was actually originally hired to work on the Evidence Now Healthy Hearts Northwest initiative. Most of my time right now is spent on the Accountable Health Communities model, but I've also had the chance to work on the Open Notes initiative. If you're not familiar with that, it's working with providers to supply the entire medical note from every appointment to the patient so they have better access and better understanding of their care. I've worked on regional surveys and some analysis for dental providers on the coast. I've been able to work for a medical scribe program and provide lots of technical assistance with Dr. Davis and others on lots of different topics. So, like I said, a lot going on. We have a pretty broad portfolio at ORPRN. So a little bit about Oregon. First of all, it's beautiful. As you can even see from satellite imagery, it is a wonderful place to be. We are the 9th largest state, which I think catches some people off guard. They don't realize quite how big Oregon is until you're there. We recently had a visit with our CMS project officer, and she was shocked to hear that it's about 6 hours north to south to drive across Oregon and about 9 hours east to west. It's huge. It's a big state, and we do work with practices on all of those borders. Though we're the 9th largest, we're the 27th most populous and 39th in population density. So that tells you a little bit something about Oregon, right? So if you look, you can kind of tell from this picture, we have a coastal range of mountains that's that first little strip of green on the left. We have the Cascade Range, which is that second strip of green, sort of in the middle of the state. The vast majority of people that live in Oregon live in between those two mountain ranges. So we have the Willamette Valley, we have the Rogue Basin, and then the Rogue River Valley. So most people that live in Oregon live there. The rest of the state is far less populated, but there's a lot of really good work happening out there. So we have someone located in Eastern Oregon, and as I said, I work in Southern Oregon. So that part down there that's the most concentrated green, that's me. So I might be biased, but I think that I have the most beautiful part of the state to work with. I think we would all probably say that if you asked us. But these are just a couple pictures of places that I've gotten to take meetings on the road over the last 4 years. So these are all places that I pulled over to have some type of web meeting while I was traveling between clinics. And you can kind of see from this, there's quite a range of terrain here. So I cover from the coast, you can see there's a picture from the beach there, all the way up through the mountains and then over into the sort of high desert. You can see I had a visit where I was parked out in front of a frozen lake. So there's a lot going on. It's a beautiful place, but this also makes it kind of difficult to travel, right? We have winter. We have real winter in some of these places, and it really does get in the way sometimes of our work. So I also want to talk a little bit about the healthcare climate in Oregon, just to set the stage so that we all understand as I'm talking through the Accountable Health Communities model what I'm talking about. So we are a Medicaid expansion state. We have what we call Coordinated Care Organizations, or CCOs. I'm going to use that acronym. I apologize. It's defined here. Hopefully everybody knows what it is. But these are the Medicaid payers across the state. We currently have 15. The contracts were up, and so there's a whole new group of contracts bids. So we'll see how many we have after that shakes out. But right now there are 15. And they support contracted clinics. So they have a panel of patients that they then work with the clinics that are contracted with them to support. And there's really varying levels of engagement across the state. So in some places, it's really good. And they have a lot of work directly with clinics. It's a great relationship. Other places, they're less handsy. They're more hands-off. So it really depends where you're at, what level of support you're getting, and what level of direct access you have to the CCO team. So this is a map of the CCOs in Oregon. You don't need to, I know you can't read almost any of that. What I really want to call out is the Southern Oregon area. So here, these 3 counties are where we're doing the Accountable Health Communities project in Southern Oregon, and there are 4 CCOs overlapping in those 3 counties, which means that at any given spot, a patient could be one of 2, or in one place, one of 3 CCOs, which adds a huge level of complexity to the work that we're doing. Patients don't always know who their insurer is, and providers often get confused about exactly where their money is coming from and where their support's coming from. This overlap also causes a little bit of consternation, I think is the right word, between the CCOs. They're competing directly. So this has been an issue in some cases. We're hoping that with the new bids, this will be alleviated a little bit, but I suppose we'll see as time goes on. So I also want to highlight just a couple statistics to set the stage for why social determinants of health work is important in Oregon. So we are currently 17th in the United States as far as our uninsured rate, which is pretty good. We feel good about that. However, we're not doing so well in some other areas. So we're currently ranked 28th for having people below the federal poverty line, 48th in our high school graduation rate, 47th in having affordable housing for people that do live under the federal poverty line, and 31st in food insecurity. So we're doing pretty well on the medical side, but we really do have some gaps to make up on the social determinants side. So that was really one of the reasons that we thought the Accountable Health Communities grant was going to be important, and one of the reasons that we've had a lot of success working with people in the regions that are doing the model. It's something that communities want, something they need. They're really looking forward to working with us on this. So let's talk a little bit about Accountable Health Communities. So what is this grant? So there's 2 primary questions that we're trying to answer here. The primary question CMS is asking is, does screening for these social needs plus tailored navigation to health and social services lead to improved outcomes and reduced costs of care for Medicare and Medicaid beneficiaries? We're not 100% positive what their total analysis will be, but basically they're looking at per member per month cost across a wide range of regions that are participating in the project and those that are not. It's really interesting. This is going to tell us a lot about how impactful this work is and what the potential economic impact is. In Oregon, we are also really interested in implementation. This is something that ORPRN does a lot of work around, is how do we implement these types of projects? So we want to know, how do we do this? We're doing this in a lot of different settings, and is there a right way? Or is there maybe a set of standards that need to be met for it to be successful? Or is it really variable, and you can kind of do it however works for you? We don't know. So this is one of the things that we're working with our sites on trying to understand. There's currently no gold standard, so we're trying to seek out what that might look like. So we're doing this by screening patients for health-related social needs. So we're screening for housing, transportation, utilities, food, and personal safety. Those are the 5 domains that we are asking patients about. Where we identify a gap, we are connecting patients to community resources, so local resources to them that could help them meet their need. However, there are definitely gaps in those resources, and we also want to know what that looks like. So where are there missing resources? Where are there gaps in our ability to meet patient need? We're providing navigation for patients that are high risk, and that's basically care coordination. I'll talk a little more about that later, but basically somebody is working one-on-one with a patient that has a higher level need to help them navigate to resources that could help them. And we also want to act as a community integrator. So as I said, there's a lot of really good work happening across Oregon. The CCOs are doing good work. A lot of the practices we work with are doing really good work around this. But it's pretty episodic. And so you've got a lot of individual agencies that are doing this stuff and not really communicating about it. Our hope is that through this project, we can put something together that's more sustainable and more community-wide so that we all can be a part of a bigger, more broad solution, hopefully that would capture more patients. So in Oregon, this is a collaborative across 9 counties. We've broken it up into 4 regions. So we've got Southern Oregon, where I work, the Gorge, the Columbia River Gorge, Central Oregon, and then the Yamhill County up there by Portland. And we are actually expanding into Portland as well. We originally started in just the more rural parts of the state. We've decided to expand to Portland to include the urban area as well. This is a 5-year, $4.5 million collaborative agreement with CMS, and the majority of that money we are reinvesting back into communities doing the work. So we're paying for the screenings, we're paying for completed navigations, and we are paying for some of the services that are being provided to patients as well. We're really trying to invest into this, have an influx of capital to hopefully help this get off the ground and make a difference. So as I said, this is being done across the state, but it's also being done in a wide range of settings. So CMS defines this has to be done at a clinical encounter. Clinical encounter is a loaded term, and it's really hard to define. So we have been able to engage with primary care, obviously. The majority of sites are primary care. I'd say maybe 2/3 of the sites participating are primary care sites. We've also been able to engage with behavioral health, hospitals, public health departments, dental providers, the coordinated care organizations, the CCOs across the state, social service agencies, WIC offices. We're just now talking about care coordinators in various places across the state being able to do this work as well, trying to expand to a wider audience to then get a better snapshot of the population. So again, we're trying to quantify this need. It's important that we don't miss people, or we miss as few people as possible. But we also want people to have the best opportunity to get access to resources. And you're not going to catch everybody through primary care. So the hope is that we can get a broader sample. So there's 3 main pieces to this workflow. So the first is the screening. So at the time of an encounter, a patient comes in or has a phone call with their provider, whatever the case may be, they're screened. So they answer the questions about these 5 needs, and then it's scored. So now if they're positive, 2 things may happen. Everybody that has a positive need gets some type of referral to resource. Now this looks a little bit different depending on what site you're at. So we have about 45 sites right now. Some sites are using a list, some sites are using specific resources they've curated, some sites are using an automatically generated list that I'll talk about in a second. Other sites are referring to a care manager, but they get something. So if you screen positive, they talk to you about it that day, and you leave the office with something that you could hopefully use to help meet your need. Then for our higher risk patients, we get that navigation, and that's being initiated within 2 days. So in many cases, that's immediate. It's a care manager or somebody that's going to that patient right then, sitting down with them and talking to them about their need. But in other cases, it may be somebody that's external to the clinic, or maybe their case manager is busy with somebody else. That outreach is happening within 2 days. So we want this to be quick. We want patients that are identified with needs to be met quickly so that it's not something that they forget about. It's something that's still on the front of their mind, and they're more likely to deal with it right then. So we've developed a custom data system for this project. So there's a lot that goes into this. This is a research study, so obviously we need to collect good data for the study. We also wanted to make it a tool that people could use for care coordination. So we worked with a team in Oregon to develop a system. It was already being used, a version of this system was being used in different places across the state to do work very similar to this. So we adapted it to meet the needs of this model. So all of the screening data is collected here. The screenings are scored automatically by the system. An automatic resource list is generated based on what the patient screens positive for and their zip code. So they get resources that are close to them. And then all the navigation data is captured here as well. So we have a pretty rich data set to work off of and to try to really understand what's happening. When a patient gets navigated to a resource, what's the outcome? What are they actually doing? What's working, what's not working? So those resource lists I was talking about, we have partnered with the Oregon 211 to provide these lists. So they have their database of resources they manage. What we did is basically took their database. Cullen and I did quite a bit of work mapping all of the resources they had in their database in these 9 counties to the 5 needs. And then that's what's applied and then updated and gets given to the patient. This is a live link. So if there's an update made in the 211 database, that is made in our database every 24 hours. So if today a new resource comes on the market, tomorrow at midnight, that goes into our database, and the next patient that gets screened has access to that through our service. It's pretty cool. So this is what those community resource summaries look like. I'm not going to spend too much time on this, but I just wanted to point out that there's a broad amount of information that goes on here. We tried to make it as useful as possible. So contact information, but also things like eligibility. We currently cannot sort by gender or age, so we have some problems like patients getting a 70-year-old male getting only WIC resources, which isn't really going to work for him. But we're getting better at that. And it is basically something that we can give to the patient. They can then evaluate and decide where they want to go. So this is a big project. There are a lot of moving pieces. There's a lot going on. And we have our hands in a lot of different parts of the state. And we have a pretty lean team. So there are 6 of us on this team. In total, we equal 2.5 FTE, which is not much when you really get down to it. And more than that, we just have 2 facilitators. So I'm covering Southern Oregon, where about half the practices currently are. Cullen covers the rest of the state, where the rest of the practices are. These are big areas. So we have run into some struggles with that. We'll talk more about that in the successes and challenges section. But I just wanted to point out that we're running pretty lean here. And this leaves us with the question, how do we convince people to do this? It's a big lift. So let's talk about that. How did we recruit practices? Quick show of hands, who has struggled with recruitment on any project ever? Okay, the rest of you are lying to yourselves. This is a really terrible process sometimes, but I'll go through kind of how we recruited, what we were looking for, and how we've engaged sites over the course of the project. So throughout the course of this, I want to talk about who our stakeholders are. And this is sort of the crux of what I want to talk about with this plenary. This changes drastically over the course of this project. So I tried to make it a timeline so we can kind of see how this was evolving as the project evolved. So at first, before we started doing any screenings, we were really focused on statewide stakeholders. So these are people like the Oregon Health Authority, the CCOs, health system or clinic leadership, mostly CEO level. That's what I'm talking about here. Local government leaders, we had our statewide 211 info partners, and then some key social service providers. So the big players in the state. This was just big picture. Let's talk about what this is on its face, how we're going to do it, and get buy-in. These people were key in helping us get buy-in across the state. They were key in reducing some of the barriers to implementation. But these are not the people that do the work, right? The CEO of OHSU or Providence or wherever isn't going to screen any patients for social needs. So we had to dig down here a little bit, and quickly this list evolved. So version 2.0, once we had funding, we had the project under our feet, we were ready to go, we had to expand to the individual screening sites. So we're still engaging those stakeholders, we're still talking to them, but now we had to adapt our message. And how are we going to actually implement this? What does it look like on the ground? More specifically though, amongst each of these types of sites, that's a different story. So primary care looks very different than somebody in a dental clinic, which is different than a public health department. Within the public health department, there's different departments that do different types of outreach and work. So you can kind of see where this gets complicated. There's a lot of different players that have different perspectives, they have different needs, they have different motivations. So that's kind of what I'm trying to get at here, and we'll expand a little more about that as I go on. But you can already see here, we've got the big picture people that are influencing the detailed people and vice versa, and trying to balance that. So for recruitment, we started with the normal methods. We had our list of clinics. Like I said, in 2018, we engaged with about 300 clinics. The CCOs brought the grant to us. They also brought recommendations for who should participate. So we started there. We had a pretty good baseline to start with. We identified key players from our network, and then there was a lot of word of mouth. And this actually surprised me, especially in the smaller communities of the state. When we would go and do a recruitment visit with one of the sites, and then go to see a different site the next day or the next week, and casually mention that, oh, so-and-so is doing accountable health communities, they were on board. That's all it took. They didn't want to be left behind. They are, competing with these people, whether it's monetarily or just intrinsically. And there was a lot of trying to keep up with the Joneses, which was really good. We got a lot of buy-in. It was also really interesting because not all of those sites had the right motivations for the project. So some of this was leading to dead ends. Others, a lot of work went into getting them ready for this. But it was just an interesting anecdote. I don't know if anyone here is familiar with the SAM.gov account process for federal grant management. A lot of our sites were not. So this is a pretty laborious, long process. If you've never done it, congratulations. Hopefully you never have to do it. But this was a real barrier, especially for some smaller rural clinics that had never done it before. Although the biggest problem we found was actually sites that were rural. They had a SAM account 10 years ago, and the person that set it up has been long gone. And now there's 10 million forms you have to fill out to get your number transferred over and get the address right, and the business name has changed 3 times, and sites dropped out because of this. We lost several sites because they were not able to get their SAM account put together. The clinic manager at one site, I think she said she spent 30 or 40 hours over the course of a month trying to get this together and calling back and forth. And eventually the doc that owned the office said, we've got to stop. You have so much more to do than just set up the SAM account. We've got to stop. So anyone in the room that has a bug in CMS's ear, just putting it out there. And then the other thing is that every lead that we got came with 2 more referrals of oh, you should talk to so-and-so. You should talk to this agency. You should talk to this provider. They'd be great for you, which was awesome. We were new. This was a whole new thing. We were trying to develop our network, but that's an exponential curve, right? This is expanding very quickly, and very quickly it got a little bit out of hand, and we had a lot of potential partners and not very many people to follow up with them. So in Southern Oregon, this expanded. I will just speak from my experience here. These are some examples of the organizations that I was referred to, and then these are the ones that I really actively tried to engage. So we have a Rogue Valley Food Council that is all of the food banks and then several other partners that meet monthly to talk about food insecurity. The Addictions Recovery Network in Southern Oregon was very interested in participating. We ran into problems with Code of Federal Regulations, and they ended up dropping out, but they were a partner for quite a while. The Southern Oregon Homelessness Task Force, again, is across the 2 counties there in the Rogue Valley. A broad range of people that come and meet there once a month. We had a Community Advisory Committee and Patient and Family Advisory Councils that wanted to be involved. Several early childhood development partners that wanted to be involved, and lots of other smaller targeted organizations that had their niche that they wanted to make sure that we were not missing. And again, this is great. We were really excited that all these people were excited about the work and wanted to be involved, but this required a lot of follow-up, a lot of staff time to go to these meetings, explain what the project was, give the exact same talk over and over and over and over again to the same people. And then, unfortunately, a lot of these ended up being dead ends. We put a lot of time into trying to get these people rolled in, but at its core, this was designed to be a primary care intervention. So we were already stretching the limits of the model by including who we were, and a lot of these groups that are a little bit further removed from the primary care sector, it just didn't work. We're hoping that it can expand to them later. We're hoping we can roll them in, but for now, it's just a little bit too much of a stretch for our team to get them involved meaningfully. So now we've expanded our sphere again, right? For quite a while and still continuing, we have our big picture stakeholders from the state. We have our individual screening sites that we're engaging with on a daily basis, trying to get them running for the project. And then now we have these resource networks, and they're really interested in the transfers of care. So even those that aren't able to engage in the project currently a lot of them are still accepting patients. They're still the resource that people are referring to. So when a patient has a need, this is where they go. And we still need to talk to them. They still want to know what's happening. They still want to know how patients are getting to them, what patients know, what they don't know. And we need to tell them this. It's our responsibility to keep them informed so that they know what's coming and they can help us inform the project. One more layer, right? This is now one more group of people that we're engaging with, getting phone calls from, emails from all the time, trying to go to their meetings, expanding a little further, right? So we have all these different audiences, we have all these different messages. Each group requires specific messaging. We can't standardize. Because we're a lean team, we tried desperately to standardize our messaging, to have a standard set of materials that we could share. And when we went to do presentations, we could do one presentation that was standard across all of these sites. That didn't work. We tried our best, it just didn't work. And often we didn't know what would work until we went and failed. And we gave a presentation and everybody in the room said, well, that's great, but what about me? What about this? What about that? And we did this over and over again. We would go into a new setting that we weren't familiar with, give our pitch, and everybody in the room would say, well, that has nothing to do with me. Talk about this. And I think we've kind of learned over the course of facilitation that that's just going to happen. But we really had to be nimble. We had to be ready to go in there, ready to be told we were wrong daily, and then ready to kind of adapt on the fly and figure out what they needed. And motivations also varied pretty drastically. So some people wanted to provide better patient care. That was their focus. Some people, this was a funding thing. They wanted the money. Some people, there was pressure from administration, whether it was a central admin or admin in the clinic specifically. And in other places, they were already doing this work. And that's kind of a double-edged sword. In some cases, if they're already doing screening, and we go in and say, hey, we want to do this screening, they get really excited because they're doing it. Maybe they have a model that works really well, and they're excited to share. That's great. In other cases, they think their model is better. They don't want to engage with ours, but they still want to show off. They still want to be part of the data, and then this is now creating a problem because they don't want to engage in the way that we need them to, but they still want to participate. So we're happy to have everybody. We will take all comers. But this has been a little bit of an issue trying to balance, how are we going to do this? We had one site that I worked with in Southern Oregon for about a year on the contracting, developing a workflow, getting everything carved out. And then at the absolute last minute, I was literally in a meeting, a contracting call, about to send out the contract to their team with our director. And at the very last minute of this hour call, we said, okay, great, any other questions? And their COO said, well, I don't think we're going to participate. But thank you, and we'll be in touch. And the director looked at me and goes, what? What did we just do for the last hour? What's happening? And it caught us off guard. We really didn't see it coming. But this is the reality, is they have a really robust program, and their administration had decided that this was not a good match for them. So that's the reality of doing this work. Okay, so we've done all of this build-up. We have our partners in place. We're communicating effectively with everybody across the entire state, obviously. And now it's time to roll this project out. So on June 30th, 2018, we had every site ready to go, trained. We had done their AHC training, their model training. We had done their research ethics training. We were proud of ourselves. We were living high. It was great. We had done a lot of work to get to this point. So June 30th. December 17th, the first screening actually happens. So obviously a lot of things took place between those two time points. A lot of stuff went into that. I don't really want to get into why there were delays. Suffice to say, there were delays. We lost a lot of sites here. There was quite a gap, and I mean, you can imagine if you have a site trained, they're ready, their sites engaged, their staff are ready, and then we're telling them month on month on month, one more month. Give us one more month, and we'll get rolling. Man, I am shocked and humbled at how many sites have stuck in it with us, but we did lose some. A lot of sites have stayed engaged. We're doing some work to re-engage people, but that's a big gap. It's a lot of time to pass between getting ready and actually implementing a project. So December 17th, we do our first screening, which, by the way, it's not lost on us. That was the week before Christmas. We got the go-ahead, and we had a site that wanted to go, and so we shot out an email to everybody saying, we can go, let's do this. and like 3 or 4 sites wanted to start, so we did it. Now, fast forward to May of 2019. So May 31st, 2019 was a hard deadline for us. We had to have our sites launched. And I mean, you can understand why. This is almost a year since we were supposed to start the project. Our first contracting year was up May 31st, and we had a whole bunch of sites that hadn't even kicked off the project yet, due to the reasons that we just talked about. So this was a big lift, getting everybody actually launched. And I'll just tell one story about a system that I work with. There were several sites that absolutely did not want to start. They just said, we're not ready, it's not time, we don't have the people, we're staffing problems, whatever it was. But we were under a lot of pressure. So there were 4 or 5 sites that I went to, and they didn't want me there, but I went anyway. And talked to their manager for an hour, did the whole thing, and then at the end they said, okay, great, go away now, we'll see you in a few months. And I said, well, can we just do one? Can we get one screening? And they said no. And I said, I'll do it? And they said no. And I said, okay, so if I do the screening with the patient, and then I enter the data, and then I do all, and then can we do it? And they said no. And then I said, okay, I really need to do one, please, and begged and begged and begged, and we got it. We got our 45 sites, but there was an awful lot of pleading involved to do that. So May 31st, we have everybody launched. Where are we at now? There's a lot of retraining to do. So this rollout process that we thought was going to be a month long, that was a pipe dream, it's drawn out over a year now. So we have a lot of retraining to do. We have to rework a lot of workflows. As you can imagine, in a year, a lot of staff have moved on. The clinics do not look the same as they did a year ago. And now we're working with them to figure out how are we going to do this moving forward. So we're still doing constant outreach to screening sites. We're helping them with workflow mapping. We're helping them with quality improvement support. We're providing encouragement. We are doing a little bit of that begging, really trying to get them to do what we need them to do. We're also providing ongoing training and onboarding. So as new people come into sites, we'll go and train them again. We'll do it for 1 person, we'll do it for 2 people, 10 people, it doesn't matter. We'll do whatever we need to do for that site to be ready to do the project. We're doing this in person, or we have webinars. We also have a weekly training webinar that our boss hosts every Friday at noon. She hops on the Zoom link, and she sits there and waits for people to join. And I think the majority of these Friday webinars have been 1 to 2 people, which feels really frustrating, but it's still happening, right? We're still getting people trained, we're getting them in, we're moving forward. But this is a big lift. None of us have the time to really do these trainings every day, but we're making it happen. We also have statewide advisory board. They meet quarterly. That's that statewide stakeholder group. We have regional steering committee meetings that meet quarterly as well. That's more of the local leadership. They're meeting every quarter and being engaged about what's happening. We give them a data report out and talk about what's going on the ground. We have a weekly work group for screening and navigation. So we started this to be a forum for shared learning. We wanted people to have the chance to talk to each other about what's working, what's not working, what are they doing. It's been pretty successful. We started with every other week. So screening was 1 week, the next week would be navigation, then screening again, then navigation. And it made a lot of sense to us at first that, well, we have these 2 workflows, we should talk about them separately. And then what we've realized is that in most sites, they're not separate. It's the same people doing both parts. So we've decided to combine them together, and now it's just once every other week, the whole group gets to meet together. And we're also trying to share workflows. So we're working with these sites. Colin and I are in clinics every day, trying to help them get moving. We're trying to identify what are the best practices here, and then share them as quickly and broadly as we can. So if we find something that's working, we will document it, slap the label on it, fax it out to everybody, make sure that everybody sees it. We want people to be successful, so as we identify these things, we are trying to, as quickly as we can, send it out to the rest of the state. Okay, so let's take a step back and look at our stakeholders now. It's changed again. We still have our statewides, we still have our individual screening sites, we have those resource networks that want to know what's going on, but we've started to parse out each individual site. So we are no longer talking to Clinic X. Now we're talking to the front desk at Clinic X, the nursing staff, the MAs, the admins, the providers, the care managers. All of these people have a different stake in the project. They all have different roles in the project, and we realize that we really can't treat them individually. So if I go to a clinic, I may be meeting with their admin and talking about the project overall. I may be meeting with their front desk and talking about how they do the data entry for the project. I may be talking to the MAs and talking about how they do referrals for the project. But this is no longer happening together. So now we sort of have this fourth layer, and we're getting really deep into the weeds about each of these individual roles and how they work in the bigger structure of this project. And we still only have that 2.5 FTE. Don't forget that. So a lot going into this. So we have this ongoing engagement. I wanted to take a second just to talk about what this actually looks like for a small team like us. These sites are requiring multiple visits, sometimes multiple visits in one day, because you go for the visit that was scheduled and somebody was out to lunch and they say, oh, can you just come back in an hour? And we'll do us now and then come back in an hour and talk to them. Sure, we can do that. We also have a very geographically diverse model, which is great because we're getting a lot of patients from a lot of parts of the state. We're learning a lot more because of this. It's hard to attend to. This is a copy of my schedule from Memorial Day week. A lot of the big white chunks there are travel, and it's just moving to and from clinics. It adds up quick. There's also competing priorities for the clinics, but also for our team. So this is not the only project we're working on. I showed you that list of stuff that I've worked on at ORPRN. We all have multiple projects. We all have multiple things that we have to do. So this is just one example. This is what all of our calendars look like. It's what they've looked like for the past month and a half, 2 months. And I imagine that's not going to change anytime soon. We really do have, we're packing in as many visits with these clinics as we possibly can to get them moving, to make sure they have the resources they need, and to get them trained up to do the project. Okay, so that's a lot. We've talked about where this all came from, who we're engaging, how we're doing it, where we're at right now. I want to end on a positive note. So this is not all bad. I know that I've been focused on the challenges we've been facing with the implementation and how we've been working with multiple partners, but there's a lot of good already happening from this project. So before I go on to the next slide, the way I've structured this is on a single slide, we'll kind of talk about one thing that has a positive and a negative. I want to focus on the positive. So just keep in mind, we're focusing on positives now. So the first one, implementation. It's been slow. We had those big delays. We've really gotten staggered enthusiasm. So some sites are ready to go day one. Some sites, it takes a year to get them actually ready to go. It's hard to manage. We've also had a lot of pressure from CMS and a lot of pressure from our local partners to get this off the ground. The upside to that, though, is our local partners are pressuring us because they care. They want to do this. There is a lot of excitement around doing this project, which is part of the reason that we're continuing on with it. The partners we're working with really see the value in it, and they want it to get done. And we're making headway. We are identifying workflows that work. We already sort of have our first draft of what is the right way to do this in primary care. We have 45 sites started right now, and our screening rates are increasing rapidly. So this is our screening rate as a state over the last approximately 6 months, of the project. So we started nice and slow. There's that big jump about 3 months in. That was a single clinic coming on board. A single clinic that we finally got engaged. They got super excited. They did all this work. They trailed off a little bit after they started, but they were super excited about the project. And then you can see in the last 2 weeks, we have quintupled the work that we're doing. We have gone through the roof, which is really exciting. We think this is sustainable. We think it's still moving up. We feel like we're moving in the right direction. We're getting a lot more momentum. It's really exciting. I also want to talk about the data we're seeing from the actual screening. So there's 2 things here. The first line there, so we've done 1,400 screenings in Oregon, and 165 navigations have been initiated. And so really think about what that means. It's a low number based on our annual target, but 165 patients have been connected to resources. Well, more than that. 165 patients have been actively navigated to resources. That's huge. We really need to not lose track of why we're doing this. It's for the betterment of our patients. We found that food and housing are the 2 most common needs. That was in Oregon. The data below those 2 pie charts, this is the model across the country. So you can see there's 2 tracks. There's been 18,500 screenings in one, and about 37,500 screenings in the other. And you can see it's about 25% of people are screening positive for needing housing. And about 1/3 are screening positive for food insecurity. So this is about right, based on what we expected to see in Oregon, and it's kind of nice and validating to see the same thing across the country. Okay, so number 2, having a continuum of care. So one of the goals of this project was to move away from episodic care, where we're dealing with somebody at each different site every time they come in, towards a more continuous model where someone could be seen at the dentist, then go to the primary care specialist, then go to the hospital, then talk to their CCO, and everybody there is keyed in to what their needs are and what they have been given as far as resources and where that's gone. That's the goal. Screening sites are worried. There's a lot of infrastructure that goes into this. There's a lot of sharing, there's a lot of trust that goes into sharing this level of data across multiple sites. There's also local competition. So there are, like I said, in Southern Oregon, we have all those CCOs overlapping. There's a lot of concern about who deals with whose patients. And it's, it's one of those crazy things that my research brain doesn't think about until I'm sitting down with an insurer who says, well, we'll deal with our patients, but they need to deal with theirs. And it's so frustrating, but I get it. It's important. We're trying to keep that context in mind. But sites really do want to do this. There's a lot of energy, even though there's concerns, even though there's questions about how to do it, they want to. They realize this is the right thing to do, and they're ready to move forward with that. And patients are so receptive to this. This has blown us away. But when a site says to their patient, we are doing this to identify needs in our community, we're trying to help people in our community get resources and get help, patients get it. They get it, they're excited. They're happy to be asked these questions. That is incredible. We were so concerned that patients wouldn't want to answer these questions because they're personal and they are sensitive, but they get it. That means a lot. Okay, so our data system. This is a great tool. We have had a lot of success. A lot of sites are really excited about using it. However, I did say that we developed it from scratch, which means it does not always work. So we have had a lot of these. We have had a lot of errors. We've had a lot of problems with people not being able to engage with it because X, Y, or Z system is broken. Our developers are doing a good job of responding to it and fixing these problems as they come up. It's funny, we had a meeting with them last week before we flew out for these conferences, and we sat down for the meeting first thing in the morning. We went to do a screening and it didn't work. And the developers, sometimes there's a give and take here where they look at us like we're crazy and they say, well, it must be user error. You guys don't know what you're doing. We had them in the room. They were trapped. We showed it, they saw it, and man, did we feel good because they were there and they fixed it while they were there, but it was like, yes, it was our gotcha moment. So it's a great thing. We're really excited to have it. The whole idea behind having our own system was that it could stay in place after the project is over. Once funding goes away, the communities using it could still have access to it. But there are challenges that come with that. And finally, and I think most importantly, the patient experience. So we've seen already lots of stories of structural change. Good things happening for patients. And I want to point out that I changed the title to Successes and More Successes because this is great. We've seen a lot of really good stuff happening already. So one clinic partnered with a ride-sharing organization to make sure their patients could get to their appointments. That's one of those things that it cost nobody anything. The service was already there. They already wanted to partner with this primary care clinic. All they had to do was plug it in. Another clinic that Cullen works with built tiny homes in their parking lot to help their homeless patients. So this was somewhere that they could come, they could stay, they could have closer access to their health care. Awesome. Is that sustainable? Who knows? But it's a really cool thing for them to do. It's a really awesome way for them to try to give back to the community when we're facing such a shortage of housing and so many people that can't get access to a dry place to live in Oregon, where being dry is really important. We also had a health system start a local resource desk to navigate their patients. So this is a system that didn't have this in place. They weren't really considering doing it. And because of this grant, they have hired somebody, staffed a desk that now is 40 hours a week there just to work with patients on these resources. So they are doing live referrals, they're going to the individual clinics and talking to patients, they're doing phone follow-up, email follow-up, they're digging into what resources are available, they're following up with patients to see what's actually working. It's amazing that they're willing to do this. And it was because we brought them this grant that they decided to do it. As I said, patients have been really appreciative of having the questions asked. We were worried, like I said, we were really worried. We didn't know how it was going to go, but everybody's been really receptive. There's always going to be the one or two that don't want to do it. That's fine. We've had a pretty low rate of people declining the screening. Overall, it's been very, very great. And then finally, connections are being made. We are getting patients to resources that they need. That is key. That's why we're doing it. That's why primary care wanted to do it. That's why all the agencies providing services to patients want to do it. We are meeting our goal. Okay, so what are the key learnings here? What can we take away from this? Number one, we need to do this. It is critical that we do this work, and people are excited about it. Number two, there are gaps in resources. We know this. We know that not everybody that has a housing need will get housing. We know that everybody that has a food need won't get food. But there are plenty of resources in place to start making progress. And just because you can't get every single one met, that should not be a reason to not give somebody something. So, like I said this yesterday when we were having the panel up here, we've had a lot of providers worried about asking these questions because there aren't enough resources. Once we actually start doing it, it takes one story, one patient that gets access to resources, and they're on board. They see the value in it, they get it. Number three, implementation is hard, time is short, and the money is somewhere else. I don't know where it is, I don't know who has it, we don't. We are still working with that really short team. All the clinics we're working with, all the delivery sites we're working with, they are short-staffed, but we're making it work. Again, I think identifying the motivation here, seeing that it's working, seeing patients get connected to resources is a lot of what we need individually and organizationally to get that we should do this even though we are resource poor. Number four, facilitator flexibility is key. Embrace being wrong. I only have 4 years of experience as a facilitator. I don't consider myself an expert, but what I will say is my number one takeaway and the number one thing I try to teach to all the facilitators that come into our department when they're new is embrace not knowing and embrace being wrong. If you try to know everything, you will fail. If you try to never be wrong, you will fail. If you try to never let a clinic see that you make a mistake, you will fail and it will be painful. So just embrace it. Go in, be ready to be wrong, be ready to be told that you're wrong, be ready to be told that you're stupid. It's fine. Don't take it personally. Identify the successes and move on. I kind of took the thunder from my second or last bullet there. It's not if, but when you don't succeed at first, identify the success and keep trying. Pick the thing out of what you're doing that worked, pick the motivation, figure out what is making people want to engage, and keep pressing it until it works. Okay, so I do want to leave plenty of time for questions. Happy to answer questions about the model, about our engagement, whatever people are interested in.
Have you all, as part of your stakeholder engagement, interacted with the State Health Information Exchange?
Yes. So we have a couple. Yes. I'm not involved directly, so I think I'll just leave it at that. But yes, they are involved. There is an effort at the state level to consolidate the work that's being done in HIEs, in this work. I think right now there's several tools that are being used by different partners across the state, and we're trying to figure out, as a state, how do we move forward in a way that's a little more continuous.
We work with the Oklahoma Accountable Health community, which they are directly tied to the HIE. Made me think of your recruitment efforts, that their clinical encounter directly triggers through the HIE. Mm-hmm. So anytime a patient checks into a clinic, it rolls over to their AHC, and we're working with them and CMS to expand that nebulous definition to include a 911 call.
That's awesome.
So that would hopefully.
That is really cool. I hope that works. The last thing I'll say about that is that I wish we could do that. The different regions of our state that we're working with have different HIEs, and they don't talk. So that's the struggle we're having right now. But that's amazing. Awesome. Good work. What else? Other questions?
Hi, Stephen. Thank you. That was really an exciting talk. You're such a cheerleader and a salesman and all of the above, and I think everybody really enjoyed that. And you talked in the end, you kind of wrapped it up by really saying how important it was to learn more about that patient-level experience. And clearly, it's pretty easy to track who gets engaged in the navigation, but how do you track the uptake of referrals, other than sort of somewhat anecdotally? That's sort of my one question. And the other question I had, which you answered, was sort of just general concern about resource overload, but it sounds like your communities are responding to that. And then if you have a way to capture sort of the uptake of referrals, is that fed back to the recruitment site?
Yeah, so we're working on that. We don't have a good model for it right now. We realize it's important. We realize that we need to do that. That is one of the benefits of the HIE, is that you have this live referral that is a closed loop. We don't have a full closed loop referral system yet, but I think like I said, as the state develops what strategy they'll use moving forward as a state, hopefully that will come along with it. Yeah.
Project management, workforce management question. You mentioned that you're responsible for multiple projects and work with multiple PIs. In addition to all of these, who manages that and how on your time, and how do you keep your 100% FTE close to 100%?
Right. Yeah. So before I answer that question, I will say that I think this depending on who you ask. Because of my personality, I'm pretty type A in case you couldn't tell. I manage my own, and I've been given a lot of flexibility by Melinda and Caitlin and others in our department to be able to manage my own time and set my own priorities, which has been great for me. I think in other cases, there's a little more structured management of how that happens. I will say that I am bad at sticking to 100% FTE. I'm trying to work on that, but it really depends. Yeah, I'm sorry that's not a very gratifying answer, but it's the truth.
Hi, Steve. Did you have any problem in terms of, like, I'm thinking you said food and housing were the most common things. Did it overwhelm the people that are providing housing and food in terms of getting so many more referrals?
Yeah, so I think it's a little bit different between the housing and the food. So quick answer is no. We have not seen that. We've seen people that are still excited about it. There hasn't been a huge overload. The problem with housing is that in most cases, the wait list is more than 6 months long. And so if a patient is referred to this and the wait list is 9, 10, 12, 18, 21 months, there's a lot of question about whether or not it's actually a good idea to put them on that list, or if we should look for something else. We're trying to teach these people motivational interviewing and talking about finding quick, small wins to help build encouragement and build self-efficacy. It's hard to do that when there's a super long waiting list and there's not much you can do in the interim. So I think in a lot of cases the referral is not being completed because of that, honestly. And I think for food, there's at least in Southern Oregon, there's more food than is being utilized. So we haven't gotten to there's the amount of food that's available and then the amount that's actually utilized. We haven't capped out what's available yet. We will probably at some point, but right now it hasn't happened. Yeah. Tara?
Well, I'm just amazed at these interventions, and kudos to you. But as a practice facilitator, I kind of laughed at the project implementation, because that life cycle is so common, where you have to recruit, you have to train, and you have a gap, and you're fixing the internal. And I'm kind of chuckling because it's like I would never do that in a clinic. We're always taught to start with one patient, a small team. And I guess, my comment is more to the group, or is there a way that we can kind of change and make our life cycles of these projects and these fundings more lean? Mm-hmm. Because I'm guessing that what might have worked better is to trial the software, trial with one clinic, start getting this set up, and then develop the training, and then go out and start recruiting. You've got patients, you've got some wins, and that lag time you wouldn't have to retrain. I don't know, I'm just kind of throwing it out to the group, because the life cycle is just way too common and it's inefficient.
Yeah, that's a great question. Does anybody have the magic bullet? Yeah, we talked about this yesterday. It comes up every time we have this conversation. The grant cycle is not conducive to the work that we do. We do the best we can. We make do. I think there needs to be structural change before that can really shift, but we're making it work.
This may be a worthless comment, but if CMS could do their site visit earlier and understand the scope of the state so they understand the distance, and like literally I have to spend hours and hours driving, so that's going to cut down on my productivity.
Yeah. So the one thing I'll say about CMS, and then I see your question, but the one thing I'll say about CMS is that for all their faults, they are just as short-staffed as we are, and they are trying to accomplish the same goal. So I want to recognize that they are doing really good work, that they are struggling with having enough people to cover the entire country for this project, just like we're having the problem covering the state. So I agree, that would have been nice. Hopefully that's a learning they take for the future.
The kind of overarching theme this time was talking about engaging communities, and social determinants is one of the major reasons why we are so desperate as a medical community to stop being a silo and be kind of fluid with the community. I work at LA County DHS, and they are, public health, social services already, but the providers I work with are very entrenched in the idea that they have a clinical degree and they are medical professionals and they're not social workers. And we are definitely, as a county, rolling out the screeners and things that you guys are doing, and moving in the direction, based on mainly policy push, that the medical community is now a social work agency, whether you like it or not. And I'm wondering if you have any insight. Yesterday you said asking is an intervention. I think just asking the question, not having to worry about having all of the answers. But I think that shift in the mindset, like all of us in this room, even if you are a medical provider, you're probably in that mindset of, community as, the medical community is part of the greater community, and these silos are challenging, but you have that grassroots thinking and all of that. But these providers I work with don't want to have that thinking. They want the people that are professionals in those areas to be taking care of it. And the challenge I have is getting them to understand what the medical role is in that social work piece. And I'm just wondering how maybe you have engaged in that dialogue, if you have any insights into that, that would be useful for maybe that transition where it's not happening as easily.
Yeah, so we had the same problem. We had lots of providers that said that this is not my job, this is not on my docket, somebody else should take care of it. I think that's still the prevailing thought. What I will say is that there are plenty of examples, and they are right in front of our faces, of patients that are receiving medical care, getting diagnoses and treatment plans that cannot be met with these needs in place. So the simple example that I always use is insulin. If you prescribe somebody insulin, maybe they're on the state health plan, they can afford the medication, they get it, they take their first dose, and they don't have a refrigerator. What do they do with it? It goes bad. They can't use it. Medications that are supposed to be taken with food. If a patient is lacking in food and not able to have a full stomach, and they're supposed to take their medication with full stomachs, many of us in this room might just take the medication. A lot of patients read the bottle, it says take with a full stomach, and they say, well, I don't have food, so I can't take my medicine. So I think that identifying some of these areas where primary care can act as a conduit, and where it's important for the provider in their treatment plan to understand the patient context and understand what struggles that patient is facing. Again, I've seen it in several places. A doc that doesn't get it gets it pretty quick once there's a success. Once you can point to their patient that they've worked with for a long time and say, we got that person food, we got that person into housing, we got that person transportation so they don't stop canceling, they don't stop no-showing their appointments, that goes a long way towards them getting what their role is. And primary care doesn't have to solve the problem. All we're trying to say is that primary care should be aware of the problem and should take that into consideration when we're developing our treatment plans.
So, Stephen, I want to thank you for a great presentation. It's funny you have to sometimes travel across the country to learn what your colleagues are doing, but I appreciate the opportunity. What I wanted to bring up, just briefly maybe at the end, well, you don't get to leave yet. And I think this is actually for the whole group. So as Stephen mentioned, many of us, or some of us, were at the Practice-Based Research Network meeting the first 2 days of this week. And one of the topics that came up there is this idea of person-centered care. But you know, so many of the way patients are treated is very much a focus on individual disease as opposed to looking at the whole person and maybe prioritizing among those complex priorities. And I was thinking of this in the panel yesterday where we had someone talking about integrated care, opioid use disorder, kind of diabetes, social determinants of health, right? And I think there's very much a parallel at the practice level where we also need to be thinking as facilitators about practice-centered care, right? And so I'm wondering, you know, you talked a little bit about the tensions on you as a service provider. You talked about the tensions on the practice. I'm wondering, how have you approached this maybe need? You're funded to work on social determinants for this project, but you might go in and think, actually what this clinic needs may be something else. And I bring this up, you know, community-based participatory research. Some of the work we heard from Kristen and Linda earlier was very much about applying the principles of CBPR, which is about meeting your partners, assessing needs, and really starting where they're at. I'm wondering how as a culture of facilitators, how can we bring that forward again as we continue to be funded maybe by individual topic-related projects when we're really caring for a whole practice? So.
Yeah, that's a great question. And I will briefly talk about this project. I think that, at least in my experience, the Accountable Health Communities project is a little more rigid than most of the projects that I've worked on. There's not quite as much room for flexibility. There are pretty solid deliverables, and I think what's different between this and a lot of the other initiatives that I've worked on is that these deliverables are a pretty huge lift, and it's fairly easily quantified. So that has been a struggle. I think most practices, if they aren't interested in doing this work, they will drop out pretty quick. What I will say is that for those that are engaged, this is another opportunity for me to be there and to learn more about them, for them to learn more about me, and to extend our relationship and identify more areas we can work on. So if they're engaged in this project, our funding, my funding, the people paying my paycheck expect me to work with them to do social determinants of health. If we are accomplishing that and they are doing what they need and they have what they need, then nobody really cares what else we do. There are other things that we could work on at the same time. There's a lot of things that this dovetails into that make a lot of sense to focus on. So medication management, transitions of care. There's lots of other places that we could put effort under the same umbrella grant that bolster the work they're doing for social determinants, but also address other issues and other concerns that they have and help to further our relationship with them.